We have a few minutes left. If anybody has any comments, please step up to the microphone. One of the things that I'd like to do a poll of the audience. Well, let's just start. Amir?
Yeah, I just have a quick question. We have a robust prostate program, and I'm constantly being asked to come and repair hernias during prostatectomies. So question to the audience, do you repair the prostate, do you repair the hernia laparoscopic during the prostate operation, or you do it lap or open, or you do it later, or opinion?
So I'll tell you, at our hospital, you're talking about inguinal hernias, I presume?
Yeah, we're talking inguinal
yeah,
hernia,
okay.
sure.
We do laparoscopic hernia repair, permanent mesh, using barrier-coated mesh at the time of prostatectomy.
Barrier-coated?
Yes, and then we leave the peritoneum
Open? So
just like we would do for a ventral hernia
So you
repair.
do TAP?
Sorry? It's a
you
tap.
You do a tap.
It's a tap, correct.
And the other, Mike?
Absolutely.
Todd?
Yep.
Also same?
I don't do it. I just have a theoretical concern. I can't provide you data, although I think there was a basic science paper about this years ago from Germany, but I have concern about putting mesh at the time of a cancer operation because there can be cancer cells shed down there. And
Is it Schumpelik? You're talking about Schumpelik, maybe?
Yeah, I think this was looked at. I'm not sure if it was a prostate cancer, but I think there is some evidence that it might not be a great idea. But there are certainly thousands of cases where this occurs, and I'm not aware of any clinical series.
What do you do, Mike?
I tell them to come back and I fix it open another day, and I don't make it hard on myself. I just do them open the next time.
Yeah.
We have a large series of exactly that. We put a lightweight polypropylene, much like Dave does.
Yeah, I'm with Mike. I think, first of all, it behooves us to have a conversation with our urology colleagues, try to identify these beforehand and come up with a comprehensive plan. But I would wait, and I do these open. Now, one thing that often gets in their way technically is reduction of the hernia contents. I think that's important. And then you're kind of hedging your bets a little bit on the chance of an acute recurrence. But I think that acute incarceration, I think that's very low. And I'll wait and do it open later.
Brian?
Ditto to the left here. I mean, basically, that's a great case to do open. Talk to your patient about it if you can beforehand. And there's nothing wrong with an open repair.
Bruce, do you fix it at the same time?
Yeah, not much different. I would, especially if there's symptoms. If there's no symptoms, if it's an asymptomatic thing, I may talk about the patient about leaving it alone, waiting till later. But I think it's one of those issues where it's do you fix a hernia at the time of bariatric surgery? There's a lot of answers, none of them necessarily right, but engaging the patient in that decision I think is real important.
And just a quick poll of the audience then, and then we'll go to the front mic and then we'll call it. One of the things we talked about prevention of hernias and patient goals and all of that. And one of the ways that you can prevent peristomal hernia is to not make a stoma, of course. And I'm talking about doing laparoscopic peritoneal lavage for perforated diverticulitis. And can I just see by a show of hands anybody that's doing that in the audience? Maybe a skewed crowd. How about who is sort of routinely doing Hartmann's procedures in that scenario? Some. That would be, there's, in general, for Hinchey 3 perforations, about a 90% success rate on doing laparoscopic peritoneal lavage for perforated diverticulitis. So in the prevention category, I would encourage you to look at that and think about it. Let's go to the front microphone.
I just wonder if the laparoscopic peritoneal lavage decreases the amount of inflammation that leads to the leak. My question was going to be to Dr. Henneford. I'm sorry, my wife was killing me on the phone when you were giving your talk, and I might have missed this, but is there a situation, or is there any literature showing that prophylactic placement of biologic mesh at the time of stoma placement decreases the risk of
So, I think that there are a couple studies that have at least been started and perhaps completed. I have to be honest, I was shocked. I couldn't find anything in the literature when I put together that talk about it, but I've heard many people, and I know Christy Harold, and forgive me if it's published, but I could not find it. I think it might have been presented. It's not. It's underway. So to the best of my knowledge, and I might be wrong, if I am, I'm sorry to anybody out there, but I couldn't find anything out there. for
Yeah,
that.
I haven't been
So-
able to either, and there's this anecdotal thing going around that doing it prevents peristomal hernia, but
I mean, again, if we talk about the literature, the two best level 1 trials out there are with permanent synthetic mesh with pretty good results. And as I said, it's been probably due to a lot of fear about synthetic mesh and probably a lot of it unfounded. It's been safe, but people just haven't adopted it in clinical practice. I think probably the most important reason is because it's rare that the person who made the hernia or made the stoma is the one who's faced with fixing the peristomal hernia. So why kind of make your life harder at the time of surgery? But this is really left with these are complex problems to fix.
sure thing. And then I know we're short on time, Dr. Ramshaw, if I may. So basic ventral hernia that you're fixing, and I hate to put you on the spot with it, but are you going to put biologic mesh in, or are you going to put synthetic mesh in?
Well, I'll give you some of the general principles, and I'll tell you right away, we're trying to measure the value of that. We don't have, and it's a local thing, like Ben mentioned. What works in one site doesn't necessarily translate to another. There are too many different variables. So unlike 10 years ago when we try to tell everybody, oh, you got to use this mesh or you got to do this, basic principles, I'm shying away from traditional durable synthetic mesh. If I'm doing an open reconstruction, an open ventral hernia, I'll go to biologic, resorbable synthetic, lightweight synthetic. If I'm doing a laparoscopic, I'm going to use a durable mesh with a designed synthetic for intraperitoneal placement. And I'm still trying to figure out with the patient subpopulations, where's the value of what type of mesh and what type of procedure.
Can I just say, I'm a simpleton. Like Bruce has all those balls in his head. I've just got like one. And so I can't, life can't be that complicated for me. So
I thought you had two.
That's right.
And they're
Sometimes
connected by a spirochete.
I have one. I lost a second. So I think you should demand a definitive answer for that. And I think in today's world, with what we know today, in a clean case, you should not be using a biologic mesh, period. You should know a technique to not need to do it. There's a million synthetic products. Lightweight polypropylene certainly isn't perfect, but it has great results with what we know. I think when you look at cost, when you look at quality, in today's world, if they cannot prove that there is an advantage, and they need to prove it first, it shouldn't be used. Contaminated cases, it's a different story. It's a much more complicated answer, and we don't know yet. But I'm curious, we got a lot of experts up here. What do you think?
So interestingly, though, that the FDA has not approved any of the biological prosthetics for use in contaminated
but the
cases.
reason- But the
Uh,
reason I asked the question is because I agree, and I think most surgeons would agree with that answer. It's just that you get so many industry-sponsored research studies that show an advantage of biologic mesh. And
Let me just say a couple things to that, because first of all, I think that in the field of hernia research, you have to accept that a lot of these studies are going to have to be funded by industry, because the NIH and government bodies and many organizations do not want to fund hernia research because there tends to be a winner, and that winner, whoever's mesh it is going to make more money. So I would caution that you shouldn't, just because it's industry sponsored, say that it's not of scientific merit. However, you have to do those studies carefully. And I would argue the opposite, that there's very little industry sponsored or non-industry sponsored prospective, and certainly very few randomized trials with biologic or synthetic mesh. So I give hats off to any industry that's willing to put their mesh in at least a prospective study. And that's rare, and there's only a couple examples out there. So I wouldn't poo-poo it, but I think that the truth is we need more data, and you should feel energized to know that hopefully when you all go home, you'll participate in this quality collaborative. We're going to find out who's doing what and give you answers to the questions that we all want in a prospective fashion with appropriate data without bias.
And
Brian,
I
you had a
just-
comment?
Now too, but up until recently, you, the doctor, have not been held accountable for what you're putting into that patient. And I can tell you right now that that time is coming, where at the end of a year, you're going to be held accountable for the costs, because the hospital's going to get paid bulk costs for some of these cases. And if you use up all your money and putting in $10,000 pieces of mesh, they're going to come after you. So the question is, how much of your own money would you spend on these things if it was really up to you and that money was on the table? My question goes back to the stomas. At Mount Sinai in New York, we get a lot of IBD, a lot of Crohn's and colitis. And this often gets left out of the stoma discussion. So you brought up diverticulitis, and that's great. But how many colorectal surgeons who are making stomas in the setting of ulcerative colitis and Crohn's feel comfortable putting in synthetic prophylactically for their stomas? Because I can tell you at Sinai, and we do a lot of these cases, it's almost zero.
Well, I think in the U.S. in general, it's almost zero, but it's time we really critically look at the literature and see that in fact, if it's done correctly, that it can be very safe. I think there's a surgeon training issue, that maybe where to put the mesh, how big, et cetera, and once we overcome that, I think we're going to go. And I think we're going to go ahead and, we're already 6 minutes over, sorry about that, but we'll all be up here if you need anything, and thanks a lot for attending.
Oh, yeah, an audience question.
Yeah, there's another one in the back.